Bismillahirrahmanirrahim. Hi everyone. In this video, we're going to discuss the utility of point-of-care ultrasound or POCUS in the diagnosis of pneumothorax and how it can be really useful. Okay, so let's start. So I'm going to start with this table. So this table summarizes what most studies consistently found regarding the sensitivity and specificity of the physical examination, chest X-ray, and ultrasound in pneumothorax. Of course, CT chest is a gold standard. You will need it not just to definitively make the diagnosis, but also to look for any underlying lung disease that could be contributing to pneumothorax. As you can see, ultrasound is superior to chest X-ray and physical examination when it comes to ability to detect pneumothorax. So sensitivity is really high. Specificity, is quite similar among the three of them. As I always say, there are 6 components of physical examination in the cardiovascular system, respiratory system, and the abdomen, not 4. And I'll show that to you. It almost always starts with the vital signs, of course. And, in pneumothorax, only tachycardia might be present. But if the vital signs are more worrisome, like, the patient is having marked tachycardia, hypertension, cyanosis, or marked tracheal deviation, you always need to think about tension pneumothorax, which is a medical emergency. Then is general examination, second component, and in pneumothorax, patient with primary spontaneous pneumothorax might look tall and slim, and they are usually young males, so that you can catch that on just general inspection. And then comes the 4 usual components, which are inspection, palpation, percussion, and auscultation. So in inspection, take a few seconds and look into the whole chest during breathing. In pneumothorax, the affected side, due to the presence of air, will be expanded, but will move less during respiration because the lung is compressed. When you put your palm or the ulnar side of the hand in the intercostal spaces and asks patient to say 99 or blue moon to feel the tactile vocal fremeris, it should be reduced. Now, vocal resonance during auscultation, you actually almost always yield the same finding as the tactile vocal fremeris. So I personally often use it, and I actually do not remember the last time I did the tactile vocal fremeris. But if your hands are sensitive, you can use it. And then when you do percussion, percussion note should be hyperresonant in pneumothorax. And during auscultation, you should note reduced or absent breath sounds. I brought in Hammond sign just for fun. It's crunching sounds heard with heartbeats, not during breathing cycle. So might hear it better in the left hemithorax. It's due to the heart pushing away the surrounding air. It varies with respiration and inpatient position. And as you can imagine, you can hear it in pneumodiastema as well. One reason why physical examination is not that sensitive is because it cannot detect small pneumothoraces. And also, patient with obstructive airway disease like COPD, they already might have similar findings on examination, even without pneumothorax. Also, PES patient, it might be difficult to elicit all these findings. This chest X-ray belongs to one of our patients in St. Agnes Medical Center who presented with pneumothorax in the right side, as you can see here. The next ultrasound images belong to the same patient as well, and they were obtained with my Butterfly IQ device. Okay, as with physical examination, I usually start with what I think or know as the normal side. This is where you should put the probe in the upper anterior chest, and then you slide up and down, right and left, to examine as much intercostal spaces as you can. This illustration shows how the sliding sign is created and produced and how it looks like in healthy lungs. So normally there is no space between the parietal pleura and the visceral pleura, as you know. So ultrasound beams will be reflected from both pleurae, and just like the diaphragm, both of them are very hyperechoic, meaning they reflect back most of the ultrasound beams, and they appear as one bright white line. Since the visceral pleura moves or slides with breathing, that sliding will be seen as well as an hyperechoic or a bright pleural line, just like you see here in the 2D image. When you switch to the M mode, when you switch your device to the M mode or the motion mode, as I call it, the normal motion of the underlying visceral pleura and the lung will be shown as sand. This is where the movement is happening. Above this is you'll see the sea and the sky, giving rise to what is known as a seashore sign. So the seashore sign is what you should see in normal healthy lungs, or lungs, with some diseases, but the diseases that do not affect sliding. So that was the patient's right side. Compare that to the findings in this right side of the patient where the pneumothorax happened. So air is the enemy of ultrasound. So when there's air in between the parietal pleura and the visceral pleura, air will basically scatter ultrasound beams all over the place, and very few, if any, will reach the moving visceral pleura. What will be reflected back to the ultrasound probe and detected by the probe are the beams reflected from the parietal pleura, which covers the underneath of the thoracic cage, and basically it doesn't move with breathing, so it's static. That will give rise to absent sliding in the 2D image, and that will create what is called the barcode sign in the M mode image, basically because ultrasound cannot detect any moving structure beneath the probe. Now, absent sliding is not specific to pneumothorax. Any disease that slows the movement of the visceral pleura can look like pneumothorax. For example, patient with severe lung fibrosis, or patient who had recurrent pneumothoraces and they had the pleurodesis procedure, they also will have slow or absent sliding. Also, a patient with dense consolidation, like in pneumonia, they can also show a similar thing. But when normal sliding can be clearly demonstrated in the ultrasound, this effectively rules out any pneumothorax. If you can clearly see a very obvious sliding, this is not pneumothorax. Lastly, if you do careful ultrasound examination, you might be able to see the sign that is 100% specific to pneumothorax and virtually diagnostic. It's the lung point sign. Lung point is where the visceral pleura is stripped off the parietal pleura because of air. Part of the pleural line will show normal sliding, and the other part will show absent sliding. The more lateral the lung point is, the larger the pneumothorax. And there are some equations to estimate the amount of air in pneumothorax, but this is out of scope of our ultrasound training. Lung point might not be seen in all patients. So if you don't see a lung point, that doesn't rule out pneumothorax. But the presence of the lung point, as we said, is almost diagnostic. Okay, that's all what I have. Thank you very much, and see you in the next video. Bye bye.